that dizziness feeling that people tend to complain about. It is, I feel unsteady. I feel kind of dissociated. Escalators bother me. Elevators bother me. Getting up and down off the ground bothers me. It is very much those other movements. And it's never described, at least from most of my clients, as like, I'm spinning.
Welcome to Life After Impact, the Concussion Recovery Podcast. I'm Dr. Ayla Wolf, and I will be hosting today's episode where we help you navigate the often confusing, frustrating, and overwhelming journey of concussion and brain injury recovery. This podcast is your go-to resource for actionable information, whether you're dealing with a recent concussion, struggling with post-concussion syndrome, or just feeling stuck in your healing process. In each episode, we dive deep into the symptoms, testing, treatments, and neurological insights that can help you move forward with clarity and confidence. We bring you leading experts in the world of brain health, functional neurology, and rehabilitation to share their wisdom and strategies. So if you're feeling lost, hopeless, or like no one understands what you're going through, know that you are not alone. This podcast can be your guide and partner in recovery, helping you build a better life after impact. Natasha Wilch, welcome to the Life After Impact podcast. I am so excited to have you because when I met you several years ago, I was so impressed with how you just kind of launched all these amazing programs and took all this information on, functional neurology approaches and applied it to your physical therapy practice. And now you've built this incredible machine where you've got 7 full-time PTs working for you, and you've got all these amazing programs. So I wanted to share with the world everything you're doing, which is so fabulous. And also, for the purpose of this episode, really have you shed some light on the aspect of balance, vestibular disorders. And these are so common, but I think they can become very complex. And people are often, trying out different therapies, and they're still left wondering, why is my balance still poor? What can I do next? So I wanted to have you just kind of shed your light on this complex topic. So welcome to the show. Thank you for being here.
Thank you so much for having me.
Yeah, why don't you start by giving us a little bit about your background, your kind of professional journey, how you got interested in concussions in the first place, and then kind of where you took it from there.
Yeah, I'm going to try and do this in a Cliff Note version because sometimes when I share this story, like everything just like comes out. So I've been a physical therapist since 2011. And initially, it's always so funny. Like, when you go into any sort of profession, you're like, this is what I'm going to do. And so initially I was like, I'm going to work with athletes, which is, I think, what every person goes into physical therapy thinking they're going to do. And I actually had a really amazing mentor who was the physio for the Vancouver Canucks and the Vancouver Whitecaps at the time. And he let me shadow him and kind of see what his work looked like. And I was not enthralled. It was interesting, but it wasn't like, yes, like I wasn't super excited and like fiery about it. And then the reason I actually went into physio school when I thought about it after is I had a cousin who'd had a motorcycle accident and became a quadriplegic. And he talked a lot about the people who really helped him get to where he was were the therapists. It was the OTs, the PTs, and that piece of things. And so that's what kind of led me into the PT world to begin with. When I graduated, I worked in public health. So I worked in the hospital system in a general rehab unit. And I split my time between public and private. And I fell in love with the neurological population, specifically more stroke, Parkinson's, MS, and spinal cord was kind of what made up what I did. And then my husband at the time and I moved to Nanaimo, which is where we are now. And when I was trying to find a job, I couldn't find one. I mean, I could have gotten a job at the hospital, but I'm a big person on like, I need to feel good in the space I'm in. And I walked into that setting and did the interview and I was like, nope. Like nope.
And you didn't want to spend 40 hours a week in that building?
Absolutely not. No. And in Nanaimo at the time, there was no clinic that was doing neuro from a private practice perspective. And it's interesting because before we hit record, we talked about the population of Nanaimo. And I was like, is there no work? And I was like, this is an old person city. there has to be strokes.
There has to be people here who need my help.
Right? So I started to do some research and I was like, you know what, like this is silly. So that's what led to actually starting Symphony, which is my clinic, was that there was this huge void in care. It was the most terrifying thing in my life. I never thought I'd be a business owner. I never thought it, which when you look at me now, I can't imagine not being an entrepreneur, but I never like thought I would be in my life. I was raised to be like, go to work an 8 to 4, get a pension, have a secure job. Like that's how I was brought up. And so opening my clinic was probably the most terrifying experience of my life. Zero regrets ever. So that's how I kind of moved into the entrepreneur space. But then the concussion space was by fluke. I always say like it was never, I remember sitting in a neuroanatomy class, like we went back to UBC and they had like as physios, you could like refresh your neuroanatomy and play with brains and stuff again, which was amazing. And I remember I had a colleague at the time telling me that she was working with concussion and she was describing it and I was like, oh gosh, I couldn't do that. And then fast forward a couple years later and an OT in town referred me a concussion client because they're like, well, concussion's the brain's the neuro, and Natasha's the neurophysio I know. So she sent me this client and I was probably looked like a deer in headlights as well, to be honest. Because I looked at this client and I'm super honest and transparent with my clients. And I just said to her, I said, look, I have no idea what to do. I said, but if you're willing to work with me, I'm willing to learn. And I always say, I'm like, thank God she stayed. And I actually think she stayed because she had no other option, to be honest. But she stayed. And I enrolled in my first course that weekend. And I've never looked back. And it's almost because then I started getting these other referrals. And the more I started hearing people's challenges, not their symptoms, their life challenges, and how it was impacting how they lived, it's like, my dad had a brain injury when I was 17, and it turned my family's life upside down. And it's like it kind of rewoke that version of me up to be like, these people don't need to be going through what my family went through. There's no reason for it today, yet it still happens all the time. And so it's a mix of like that piece is my fire, as well as just the continuing to hear the stories that our clients go through because they are prevalent. And that's kind of what keeps me going today. There's Cliff Notes.
Okay. Amazing. And then you have a really, unique way as a physical therapist where you're actually doing 5-day intensives with your patients? I've been drinking Purity coffee now for over 2 years. And one of the things that I absolutely love about Purity coffee is the fact that they do rigorous testing for mold toxins, pesticides, and heavy metals, which allows me to be able to drink their coffee and rest easy knowing that I am not consuming toxic chemicals, mycotoxins, or possibly heavy metals. I know a lot of our listeners are paying a lot of attention to their health and trying to do everything they can to stay healthy. And if you are a coffee drinker, one of the things that I would recommend is making sure that you're drinking a coffee that isn't putting more toxins into your body. If you would like to try Purity coffee, you can get 20% off your first order using our promo code LIFEAFTER20 by going to puritycoffee.com and entering that in the promo code box at checkout. Yeah. So talk about kind of what that looks like from a PT perspective. And let's say somebody comes to you for a 5-day intensive, where do you start with them? And I think also I would love to hear kind of that functional twist that you can put on maybe balance testing, because balance testing can be super basic or it can be incredibly comprehensive. So let's kind of see what that looks like in your clinic.
So what's funny is I've actually been doing intensives since I graduated PT school. And I would do them with my strokes and I would do them with my spinal cords, but completely not through a functional neurology lens because I didn't have any training. It was all through, I was an advanced Bobath practitioner. So it was all through like neuro PT lens. But I've been doing intensives my entire career, but started doing them with concussion in 2019, more so. Balance is absolutely a piece that we talk about and that we assess in it. So I'll go a bit deeper into that in a second because I have my qualms with how balance is done a lot sometimes.
That's what I want to hear.
But an intensive is, so it's 5 days. Ours is 3 hours of a day, ultimately. Day one is comprehensive deep dive assessment. We're looking into all the systems, what's working well, what's not working well. I would say what's playing nice in the sandbox and where are things falling apart. Because, I mean, and you see this too, I feel like so much of, especially the PT world, but so much is done in silos, and then it's not integrated. And I don't believe you can treat concussion that way. It just doesn't work. So day one is assessment, and then we treat Tuesday, Wednesday, Thursday. Friday, depending on how the person's feeling, we might have a treatment session in the morning, or it's reassessment day. And then I actually also follow people then for 3 months virtually after they leave the clinic. Because what I found was, yes, we get wins in that week in the clinic, but when you come for an intensive, you're in this beautiful little bubble where the only thing you have to worry about is you. And then you have to go back to life. And so there's this transition period from intensive back home that some people need support in. And, they leave the clinic with a home program, but we almost always have to modify it once they get home based on life demands. And I didn't want people to have to try to figure that out on their own, because then it was just going to impact the changes we had. And what I found,
or they might just give up entirely.
Yeah. And then it's like, then what did we get out of it? Right. And so what I found was that if I support someone for those 3 months virtually after, we are able to support them in that transition. And then we continue to help them move forward over the next 3 months. And we're celebrating wins the 3 months down the road that we weren't able to celebrate when they left me. So that's how our intensive format looks like.
Yeah.
In terms of balance, so in the PT world, generally speaking, when we assess balance, so some clinics have force platforms. So we have a force platform in our clinic. So we'll assess, we use the modified CAT SIB a lot. So, what do they look like on firm, foam, eyes open, eyes closed, that sort of thing. We'll use like a tandem gait balance test as well. We do a bunch of different balance testing as a whole. And in the PT world, and what I see happen a lot is that they assess balance in that way, but then if the exercises to treat balance are balance exercises, so let's just practice tandem stand in a corner and see how you do. And it infuriates me. Like, it actually gets under my skin and grates because all you're doing, in my opinion, is helping fuel compensation strategies when you treat balance in that way in the beginning. Because when we look at balance, we know that balance is made up of how the systems integrate. The balance is made up of how your visual component of your visual system, your vestibular system, and your somatosensory system. So I very much take a macro to micro approach in my assessment and my treatment. And macro is, when I think macro, to be functional to like super specific. And so, I could just put someone in a corner and have them close their eyes and like do things. But if their vestibular system is shit, all you're doing is driving somatosensory compensation, or vice versa. So for me, it's okay, let's have balance as a measure for sure. And it's my favorite thing to show clients because we have the force platform measures on day one. My clients do not get a singular balance exercise ever. And then we assess the ocular motor system. We assess the vestibular system. We assess the somatosensory system. Also, sorry, I can tangent on so many things here. The somatosensory system isn't included in concussion research a ton. It's there though. Like, if people actually go digging for how the somatosensory system is impacted after concussion, it exists, but it's not in the phenotypes. It's not in the profiles. When you look at the big research, it's not in there really yet. So you have to go digging for it, but it exists. And so my job is, as I look at those systems amongst the other ones very specifically and into those micro components, and I treat those pieces. And then as those pieces improve, then you can go back into balance. And I love it because my clients who have like we talked about earlier, I'm never practitioner number one. I'm practitioner double digit, take your pick. And so they've been given balance exercise after balance exercise. And they come to the clinic and we do their force platform on day one and their vestibular scores in the hundreds or 200s or goodness knows what. And then we don't do a singular balance exercise. And you watch those numbers change by Friday drastically. And they're like, what did we just do? And I was like, because balance is the combination and the integration of these other systems stepping up to the plate their way they're supposed to step up. And if we don't figure out why your balance is terrible and we're just training balance, all you're doing is training a compensation and you are going to plateau because you can only compensate so much. That's my viewpoint on it.
Yeah. Well, and I see too, you mentioned people have a hard time in tandem stance. And so then their therapy is stand in a tandem stance and practice that. Or someone has a hard time standing on one foot. Let's practice standing on one foot. How do you feel about the habituation exercises? Because I see a lot of people come in and they basically have hyperactivity in their system. And then they're given exercises that drive the hyperactivity by let's walk around and move our head in a bunch of different directions and bend forwards and pick things up. And if you get dizzy, maybe if we just do it over and over again, your dizziness will go away. Talk about that.
Yeah. I mean, and that's what most of vestibular rehab is in my world, right? That is a big piece of it. And I think there's a time for habituation exercises? Yeah. Is that I'm always going back to, why are you getting dizzy to begin with? And I think that habituation is, okay, we know you have dizziness. We don't necessarily really know why, or we know there's this, so let's just train it out of you, which is exactly what you're talking about, right? So your brain can be it's just now you just can basically ignore it. You get used to it. Versus let's pause and let's take a step back and let's figure out what's not working in this system or systems that's making you dizzy first. I think the biggest thing when people come for an intensive is therapists struggle to do that piece, right? And so therapists feel the need to just keep layering pieces on or making things more complicated. And a lot of the time, I have the first thing I'm doing is peeling it back to the most simplistic piece. And because that's the piece that's missing. I always say gaits are people can relate to gait. It's okay, you broke your ankle and your cast comes off and the ankle's weak. So you can't plantar flex, you can't toe off very well. So your gait looks funky. Well, that your gait's funky because your plantar flexors are weak and you can't toe off. And so let's strengthen your plantar flexors and then put that back in gait. But for some reason in the concussion world, we lose that macro to micro mindset and we go, oh, well, let's just practice the gait. And so when I teach, it's very much that piece of stop, because I think in the concussion world too, and there's certain people that you look at very much not in the functional neurology world that are concussion rehab needs to be functional. And I'm well, I agree with you when they're ready for it to be functional, because you need the smaller pieces and the reflexes and these micro pieces to work to do the functional task, because those micro pieces working is what our body unconsciously uses to know where we are in space. And if we have to consciously try to know where we are in space, we're always going to be using more energy and more thought process and more cognitive power to do a functional task than if we don't have to.
Yeah. So let me put you on a spot. When somebody says, when I bend forwards, I immediately get the head pressure, the headache, and then I stand back up and I get dizzy. Talk about your kind of differential of what are the exams you're looking at? What are you thinking about? And what are you possibly seeing kind of, if there's ever a pattern with the people that come in, because that is such a common thing people have.
So instinctively, I go to two areas I know I'm going to want to look closer at. One, I'm going to want to look at autonomics. So is this a blood flow issue? Is this when we bend forward and we come back up, Are we seeing a drop in blood pressure that we can't maintain blood flow to the brain? So it's bringing in that lightheadedness and that feeling of syncope. So I'm also going to dig deeper into what those symptoms are too. So it's like, is this dizziness? Is this, do you feel like you're going to faint? Is this like, does your world feel like it's going tunnely and dark? Like, let's dig deeper into, I hate, dizziness is a terrible description, but it's the word everyone uses, right? So then I always dig deeper into those symptoms too. So there's one piece that I'm definitely like, okay, so we're changing postural demands. Like there is an element of gravity. Like what is happening autonomically with blood flow? I want to look at that. The other piece is that forward tilt movement is a component of the otolithic system, the otolith of the vestibular system. So then I'm going to be like, okay, well, what's happening in my otolith? What's happening in my saccule? What's happening in my utricle? What's happening in the rest of the vestibular system that when I do this tilt of what should be those organs kind of processing and helping us know, we're now getting these symptoms. So instinctively, those are the two flags, let's say, that go up for me. And then I'm going to go deeper into each of those systems in my assessment.
Talk a little bit about, what else are you doing when people, you mentioned the otoliths, the utricle and the saccule. So for our listeners, the saccule tells us whether we are going up or down, like when we get into an elevator. Utricle, are we moving forwards, backwards, side to side? And so when people often, like you said, dizziness is one of those words that you hate because people use it to describe all kinds of things. Mm-hmm. Now we have kind of in the literature this concept of non-spinning vertigo symptoms like the rocking and the bobbing and the swaying. And so a lot of times those are the symptoms that I think often get missed and overlooked and just kind of like, they're just not paid attention to as closely as they need to, but they can really affect someone's quality of life because they just always feel off. Mm-hmm. And so talk a little bit about kind of, again, your assessment of, the otolithic system and how do you talk to people about these symptoms? And let's just kind of dive into that because that's also a topic I love and something that, like I said, often gets overlooked in standard therapies.
The otolith gets missed all the time, like all the time. From people who are vestibular specialists, it gets missed all the time. People are comfortable doing head shake tests. They're comfortable doing head thrust tests for the semicircular canals, and they don't know how to assess for the otolith. And people also tend to equate the vestibular system with dizziness, as in like that spinny feeling. And if that doesn't happen, then they're like, oh, the vestibular system's fine. But when the otolith is involved, it's not actually that dizziness feeling that people tend to complain about. It is, I feel unsteady. I feel kind of dissociated. Escalators bother me. Elevators bother me. Getting up and down off the ground bothers me. It is very much those other movements. And it's never described, at least from most of my clients, as like, I'm spinning. And so when I'm looking at the otolith, I'm looking at like a bunch of different things, but when I'm looking at skew deviations, I'm looking at, is one eye higher than the other? The otolith plays a huge role in our relationship to gravity as well. Blood pressure too. I just had a client who has been diagnosed with POTS. The postural orthostatic tachycardic syndrome. There we go. Such a tongue twister. Because when she stands up, her heart rate changed by 40 beats per minute and it's sustained. Except that when you also look at her blood pressure, she's actually got orthostatic hypotension. So of course her heart rate is spiking up, right? And then when you do, so again, I think when we're assessing, we always have to have that like curious thing of like, why? Why is she orthostatic? Well, the otolithic system has a reflex that links into our medulla that help trigger the sympathetic system to help with postural responses to blood pressure so that we don't go hypotensive. Well, when you dig deeper into her assessment, she had significant dysfunction of of her otolith. And so her rehab to help with her orthostatic hypotension was to help with that otolith. She didn't complain of dizziness when she was standing up. She was lightheaded because she was tachycardic, and understanding those links. And so for me, when I'm looking at the otolith specifically, it's, what is happening with skew deviation? What is happening with subjective visual vertical? What is happening with ocular tilt? And then what else are you telling me in terms of, if I'm sitting someone on a plinth, And I go to move the plinth down and they're like, oh, I'm like, okay. There's nothing postural changing here. The only thing I'm doing is a linear input or like, and it's like, okay. Like, so there's things in the assessment kind of that we do too, but then also always listening to the client response and the specificity on when they're like, we're just paying attention to be like, oh God. And you're just like,
right.
oh.
Yeah.
But it is absolutely a piece that gets missed over and over and over again.
And do you do a lot of therapies where you are translating people forwards, backwards?
Yeah, it depends. So every client is different. It really truly depends on it depends on kind of where they're at and where we're seeing the dysfunction, right? So we do use linear translations for sure. It just depends in which context and all those pieces. Yeah.
Mm-hmm. Yeah. Yeah. I had a patient the other day who I'm working with on motion sickness, and I kept now that we've like done all these different therapies, I was like, okay, I need you to like get in the car and have your wife drive you around the block because it's always when he's a passenger, right?
Right.
And it's always because he's wanting to do something on his phone when he's a passenger in a car, and immediately that triggers the motion sickness, and he kept forgetting to do that. So finally I'm like, all right, we're putting you in the wheelchair. I'm going to have you play games on your phone. We're running around the parking lot in the wheelchair.
We have this one exercise. It is literally, I have a rolly stool, and there's like really long, like bungee things. It is so fun. Oh, and now I'm in my hallway. So I'm sitting, literally this is so we did this with my last intensive client, one of my last intensive clients. And so he's sitting on the stool and he holds one end of the bungee and then I have the bungee on and I like lever my body and basically slingshot, but like not with tremendous speed, him forward down the hall.
Okay.
And it's and then as I like run backwards, and it's quite fun because then it's not self-initiated, so it's kind of that they have to respond to it and all those pieces. But it was hilarious because I don't get a lot of my clients are too symptomatic for us to be there. And he was quite high functioning in a lot of levels, so we got to do some really fun, different stuff with him that I don't get to do a lot, to be honest. And so where we like slingshot him to, such a bad term to say it, I'm not actually slingshotting anybody, was into my reception area. And my receptionist and my clinic manager are like, well, that one's new. Like, that one looks like fun. Because they see us do all our stuff because we have this one main hallway in our clinic and the one end is the reception area and then the treatment rooms. And so we use that
people
hallway.
Are constantly like walking down the back doing different things.
Yeah, that hallway gets used for so much stuff. They were like, that's a new one.
Well, and that's what I love is the creativity that, so many people with that functional neurology mindset apply to their therapies I just love the creativity. I love the things people come up with. So bungee cords and slingshotting people forwards. Awesome. Because like you said, it's, it's passive in the sense that they're not pushing themselves or it's like they're not necessarily in charge of the speed. And so like that kind of unknown element has a big impact too.
Yeah. Well, and I think as someone, because I educate other clinicians as well, I think that what happens, and when you come into my program, and the functionality space too, but I don't give my clinicians a library of exercises. I'm not like, here's your vestibular exercises. Here's your exercises for the otolithic. We will talk about it. But what I really try to teach is the concept of you need to understand how this system works. You need to understand what its job is and how it should be presenting so that you can truly understand how it's not. And then when you understand those pieces, you can build an exercise to help it bridge back versus, because I was the therapist however many years ago, that did a course and it was a great beginner course. And they give you a stack of like, here's a bunch of vestibular exercises. Here's a bunch of vision exercises. But in truth, Ayla, it's like, you don't know why you're getting them. You don't know why you're doing them. You're just going back and like, here's a vestibular exercise. I'm going to use this one. And so unless you take the critical thinking skills to be like, why would I use this one? And this is honestly what led me to functional neurology, was because I recognized that I was having great change and we were becoming the go-to clinic for like our area. except that I was like, why am I doing this way? And I started asking why a lot. And no one could answer my questions. I was like, why are we doing this bilaterally? Why are we doing this direction? Like, why are we doing this exercise here and not here? And I started asking a ton of whys. And I couldn't find the answers. And that's what kind of led me down to the functional neurology rabbit hole, in that aspect of it. So,
yeah. And so on that topic, let's talk about the VOR, because that's another hurdle that I see, is that lots of patients that come to me that still have a lot of balance issues and disequilibrium, and they just feel off. And like you said, kind of these dissociative sensations. And they said, well, yes, I was already referred to PT. I already did PT and it didn't help me. And usually when I asked them, what did they do? Well, they gave me VOR exercises where I had to shake my head back and forth really, really fast.
Yep.
So let's talk about why that doesn't always work for people, and also maybe talk about the importance of like what needs to be the foundation first before somebody can even do those exercises, and when are those exercises appropriate versus when are they not appropriate.
It is the go-to exercise in my world. And I'm sure, and it has its place, I'm sure. And I should preface this with like, I don't treat any peripheral vestibular stuff really. Like everything I do is concussion and central. I should just like caveat to that piece. But it comes back to, okay, so when we're thinking that like micro to macro, normally people think of the VOR as the micro to something else, but let's actually now think of the VOR as the macro. And it's like, what is required for us to even be able to do a VOR exercise? Well, one, you got to have stable eyes and you got to be able to fixate on a target, and you have to be able to, in the context of we're talking about this exercise, move your neck. So if you can't do those three things, you're not going to be able to do a VOR exercise. I had a client once, so he travels to the island from Boston, and he had failed out. I put in quotations because I can't know if there's video, of several vestibular rehab exercise programs. Because the second that you took this man's eyes off midline, he'd go into a flutter. His eyes were an interesting thing. And so you can't do a VOR exercise because your eyes don't stay in ortho alignment when you're right. So he couldn't do it. So he couldn't do any of this vestibular rehab. And so he failed out, and he was taught to compensate. So he was taught to basically move with VOR cancellation, eyes and head together, and really like he had great peripheral vision and he was taught to compensate. And so it's kind of that piece again of being able to look at the task and break it down to its components. And then the dilemma is then people get stuck on like, well, if there is involuntary eye movement, what is it? Is it a square wave jerk? Is it nystagmus? Is it ocular flutter? Like, what am I seeing? And then if I see that, what do I do about that? Right? So we have to, again, stabilize. We have to be able to fixate, and we have to be able to move our necks. If we can't do those three things, we can't do a VOR exercise. I think the other thing, the PT world that we sometimes don't recognize in concussion is it can be asymmetrical. And so if you're having someone, and I don't know if it's actually, but the way I think about it is like if we're way down low on the left side, say hypofunctioning, and we're like up on the right, the way I think of it is we can train asymmetrically to bring them to the same level. And then we can train symmetrically to continue to build and grow. But if we're just doing everything bilaterally, how are we?
You're reinforcing the difference.
Exactly. So yeah, from a VOR perspective, you have to be able to turn your head. Like it's never an exercise ever, an exercise in my clinical practice. And I've treated, I don't know how, when you put our Jane, we're on client like 5,000 something or other. Not all my clients, obviously, but it's never an exercise that I give ever. And we're always paying attention to the asymmetries, and we're treating the asymmetry. I always say too in concussion, whether it's a VOR you're looking at or an OTR or whatever it is, it's not black and white. It's not that it's there and not there. I always say we play in the gray. What is the nuance? What is the asymmetry? We're treating the asymmetry. It's not that it's going to be present. It might be present and not present, but you can't let that be the case. It was interesting. I was going over a VOG with someone, and I'd said to the therapist, I said, tell me what you see. Because we use VOG a lot to look at vestibular system, to look at cerebellum, to look at where do you know where you are in space, because you're in the dark, right? And the person was just the client or the therapist that I was working with was like, oh, it's normal. And I was like, hey. And I was like, well, let's look at it together. And again, I think just both honestly functional neurology trained clinicians and those who are deep in concussion know where to see the nuance, right? It's like when I pull up this VOG and I'm looking at a therapist, I'm like, do you see those beats in nystagmus? Like those shouldn't be there. And it's like, well, it's not continuous. I'm like, no, but it doesn't have to be. Look at what happens when this person goes right versus when this person goes left. You're looking at two completely different stability levels of eyeballs. When they go up, are they going up? No, they're looking off to the right. Like that tells you where they think up is. Like all these pieces matter to build these treatment plans. And I mean, VOR is, so when we're moving into the traditional, like, okay, let's just move our head and blah, blah, go there, sure, after we know that they have stabilized, that they can fixate on a target, that they can move their head, and that asymmetry they're symmetrical. Then go challenge the system and push it and go into more that level of it. But don't do it until you at least get there.
No, I think that is so important. And like I said, I hear that story over and over again that people are like, I did physical therapy, it didn't work. And it's like, well, physical therapy is such a huge field. There's so many different people, specialists, and even people who maybe you can speak to this too. Like within PT, you have people who call themselves vestibular specialists, but even within that subcategory, there is also a huge amount of variability between what that means.
Yeah, and you nailed it in the sense of like, it's a huge scope of practice, huge. And what happens is because vestibular is such a significant component of so many people with concussion, right? When you look at the profiles, they say about a third of the people with concussion have a vestibular-ocular phenotype. Vestibular therapists kind of were like, by default, whether they wanted to or not, had to start treating concussion. And I always say a vestibular therapist is not a concussion therapist, and a concussion therapist is not necessarily a vestibular therapist. And when you look at the vestibular system, and I'll say, like, if you have Meniere's, if you have like the different, some honestly, even like some of the different, all the maneuvers to treat BPPV, oh my God, I've lost track. Like, there's so many, it's insane. There's always a new one being invented. Right. So when you look at the vestibular system, we have like our peripheral system, which are like our neuritises, our BPPVs, our Meniere's, our all these, which are affecting the end organs of this system, which we know is going to then eventually have a central impact. But then you have something like concussion, who I've just, that with concussion, if there's not, that doesn't mean there needs to be damage to the actual structures of the system. Concussion is more a central issue, and how the vestibular system information is being integrated into our kind of brains and function. And so many vestibular therapists, I have a vestibular therapist, I have a bunch of them in my clinic, but a couple of them who've gone through kind of the PT gold standard. So the PT gold standard in vestibular specialization is through Emory. And it is like, if you're a vestibular therapist, like that's what we do. I have not done that program, but I have two therapists in my clinic who do. They would kick my ass in treating a peripheral dysfunction. Guaranteed. They don't when it comes to concussion, because concussion is so much more centralized. So there's absolutely a difference. And that other piece too is a vestibular therapist, their knowledge is deep in the vestibular system, but a concussion doesn't just affect the vestibular system. And it comes back to, we need to understand how the neurophysiology is so important, and understanding that piece of it, because we need to understand how that vestibular system interacts with every other system. And it's, again, it always comes back to, it's the integration of all of it together that makes the difference. So you probably say this to your, but I was like, if you've seen one PT, you've seen one PT.
Fair, very fair.
We know that with concussion and any like chronic illness, there is a mental health component to it, because it's freaking hard, right? Your life gets turned upside down, and like there's grief that needs to be processed, especially if it's persistent. Like you need to go through grief. You need to go through some anger. Like guaranteed you're going to need to do some mindset work, right? For a lot of people with persistent, there's an element of trauma history. And if not before, the experience of trying to navigate this system has likely led to some trauma. And this same kind of conversation came up with someone too, of even in the mental health space, you're seeing the same thing, right? And so I can speak to it from a level of like, I'm going to say I feel like I've completely moved through it at this point. But like at one point I had PTSD that was horrible, right? Like I was having intrusive nightmares and I was having nightmares, intrusive thoughts, like on the regular. My short-term memory was terrible. I was forgetting stuff left, right, and center, brain fog. Like I would wake up nauseous and stay nauseous until I went to bed at night. Like it was horrible. And this same concept is happening in the mental health space of you just need to do the breathing, and you just need to do the cold plunging, and you just need to do these tools to help regulate your nervous system, which again, 100%. And if you don't address the root of the trauma, and I'm not saying that there's just one way to do that. There's multitudes of ways. For me, EMDR was a godsend. But if you don't address the trauma and do the work, you're always going to have to do this. And I always say to people from that mental health piece, like it is, and even probably from a treatment perspective too, from like in a concussion or chronic illness, is doing the work. I'm going to swear for a second. Doing the work is fucking hard. And it can be terrifying, because if you make the decision to do the work, whatever that work is, there's a huge element of unknown. I don't know how this is going to make me feel. I don't know what else might come up that I'm unprepared for. I don't know how this is going to impact my job. I can full on to say from my personal experience that I knew I needed to do the work. And that unknown was what stopped me from doing it for years, because my clinic was doing really well. It was booming actually. And like I was in a good spot, and my marriage was going really well, and all these things. I'm like, if I start to deal with that, I don't know what's going to come up. Like I don't want to do it.
Why would I stir the pot when the pot's pretty good right now?
Right? So I like pushed it and shoved it and shoved it. And by the time, to the point where it was 17 years later from like the major incident that led to my PTSD.
Wow. Mm-hmm.
It was like, fuck you, Natasha. Like you don't get to shove me down anymore. And it was in my face, and it was destroying my life.
Wow.
And so it's that piece of whether it's therapy for your concussion, because people get in this bubble, right? Like you probably see it too. Like they know what makes them comfortable. They know what doesn't flare their symptoms. But when you do that, your world just shrinks more and more and more. And it takes a decision to decide to do the work. And it's terrifying. And I don't think we acknowledge that enough for our clients, because there is so much uncertainty and unknown. And we like to be in control, right? Like we like to know things. And so not only is there like, there's the potential this is going to make me feel like shit, because it probably is, guaranteed. But I don't know what else is going to come up. I don't know if my job's going to be impacted. I don't know if I'm going to like what comes through. What if I don't like the person that I discover who I truly am? And I don't think as clinicians, I don't think we give our clients enough recognition of that as well.
Mm-hmm. Yeah. And that's a really big topic. I mean, I've certainly had people where it just became really obvious to me that they were trying to do all the right things, but because of the trauma and where their nervous system was stuck in the trauma, their nervous system wasn't in a place to really be able to do visual vestibular integration work, because they were still stuck in the trauma, and their system's like, I can't integrate any of these other wonderful therapies yet. Like I've got to get this other stuff figured out first.
Absolutely. Yeah.
Yeah. I think sometimes that's the nice thing. Like you have your kind of isolated community. When I lived in Bend, Oregon, that's also very much like an isolated community. You're surrounded by mountains and desert in all directions, and you had all your great referrals for these things.
Mm-hmm. Well, I have them in my team too, right? So like I have chiropractic, kinesiology, speech pathology, occupational therapy, physical therapy, and counseling in my own clinic.
Oh, wow.
Yeah.
Okay. So you've built out all of that within your awesome.
Yeah.
Amazing.
And then we have a network as well that we can refer out to.
Do you need an acupuncturist?
Do you want to move to Canada?
Living on an island sounds great.
It's a beautiful island. But yeah, no, I very much practice a holistic approach to care. Because you're not treating a diagnosis, you're treating a person. And the same way we talk about how our systems integrate, everything of who we are as a being needs to integrate. And so when I built my clinic from day one, that was always the vision of where it went. And it's just become that much more prevalent, and the necessity of it all when I shifted into more concussion and vestibular stuff.
Yeah. I refer out for EMDR a lot, and I wish that I had somebody like in my same office, because a lot of those people have huge waiting lists. They're booked out. I'm bringing somebody on the podcast here in a few weeks who she specializes in adapting EMDR to people with brain injuries. So
Amazing.
I'm super excited about that.
I'm going to listen to that one.
Yeah. I'll let you know when it's available.
I did a conversation with a therapist. So after my intensive clients leave, if they have teams in their home community, I will do a call with whoever on their team they want me to do a call with to help that process. And so one of my clients had said, "Would you speak with my therapist?" I was like, "Absolutely." And it was amazing because this therapist was like, she opened my eyes to, she's a trauma therapist. She's like, "But we don't learn." And I was like, "Well, you need to be able to shift it and adapt it. And I was like, here's the process or the hierarchy that I would take leading to EMDR with someone with concussion. And here's the adaptations. Here's the things that I would do. Here's how you can work with their therapist to know which sensory stimulation to use more." And that was the cool thing with our clinician is don't use eyes. It's just a general rule. Don't use eyeballs. But right. Even with because I assess how does our person process vibration left versus right? How do they process pressure? And because the next go-to for a lot of EMDR therapists is the vibration little tacty things in their hands.
Right. The buzzers.
But I can't help but think, and again, I'm pretty sure this has never been researched, but I can't help but think if we are not processing vibration through one side of the body as well as the other, then how is that going to impact the processing of the trauma? And so what I would do with my EMDR therapist is I'd be like, okay, vibration's good. Or it's like, vibration's not great, but their pressure sense is good. So she would use pressure as the sensory stem bilaterally.
Through tapping or tapping? Else?
Okay. Through tapping. And then when I could, as her modality. Or because they can do auditory too. Or it'd be like their auditory localization is great. They don't have hypersensitivity. So we would communicate based on our assessment to help guide her to know which sensory stimulation to use for her EMDR intervention. And I think that's where our professions can communicate and learn more from each other as well.
Absolutely. I love that. That's amazing. Well, we covered a lot of different topics. Why don't you let people know where they can find you? Because you also were just telling me you have all these amazing free resources too. So would you be willing to share? Yeah.
So for those, I would say those on a healing journey. I don't ever use the term concussion survivor ever. So for those on a healing journey, I have a program called Concussion Mini School. So it is completely free. It is 2 live group coaching calls a month with me. And then you have a private community, which is on Facebook, with all the other mini schoolers. And then you actually have a members library that is chock-a-block full of resources. So past video topics on elements of clinical focus, so exercise intolerance, dysautonomia, the vestibular system, which is what we're talking about today, actually, in mini school. More mindset focused type things. We're talking about boundaries and communication and self-compassion and those elements of things. And then we have lifestyle type things, so nutrition, that sort of thing. And it's completely free. So if it interests anybody, honestly, if you're on Instagram, so my Instagram is just @natasha.wilch. I'm the only one in my DMs. Feel free to send me a DM and I will send you the link. I can give you the link to go on show notes as well. So,
okay.
Yeah, those are probably, Instagram is the best way to reach me, or email. but I'll give you some links.
Awesome. I know that people will appreciate that. And I know how much time it takes to make even just a short video. So kudos to you for finding the time and making that happen and putting all that free content out there. That's incredible.
Thank you. Yeah. My big mission and like my big mission is to elevate and set a new standard for concussion education and treatment in the world. And we do that by things like this, right? By having conversations with other people who share that passion and continuing to spread the word and work together, because it is not one person is going to make that happen.
Yeah, absolutely. You know, I stumbled on a Reddit thread once and it was titled, something about like, I'm so tired of my doctor not knowing what POTS is. And somebody had said they came in, they're like, I have POTS. And their doctor's like, what? You're growing marijuana? They're like, no, I'm not talking about pot. I'm talking about POTS.
Oh my goodness.
Yeah. I was like on an exercise bike reading this, just dying laughing.
I would have burst out laughing if I read that one too. That's yeah.
Yeah. So you're right. We, everybody in the field needs as much knowledge as possible because it's so complicated. And like you were saying, dysautonomia is like all the rage on social media and TikTok, but it's like, it's such a complicated thing. You can't just, there's not much you can do in a 30-second video if you're trying to talk about the autonomic nervous system. And that's the problem when people are getting their information from social media is there's a bunch of stuff out there that is, it's just not specific. It's too short. It maybe captures like 1/0010th of the pie. Like, it's just, we have to really appreciate the complexity of it. And I think that's what gets missed in the social media craze of trying to make little short videos on topics.
No, I'd agree with you on that. It's a thing too. It's like, you never see me do a how-to for that exact reason.
Well, this has been great. I appreciate your time. Thanks for coming on the show.
Oh, thank you so much for having me. We'll have to have you come onto mine because I want you to talk a whole lot more about acupuncture.
Okay, let's do it.
Okay. Thank you so much.
Medical disclaimer. This video or podcast is for general informational purposes only and does not constitute the practice of medicine or other professional healthcare services, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information and materials included is at the user's own risk. The content of this video or podcast is not intended to be a substitute for medical advice, diagnosis, or treatment, and consumers of this information should seek the advice of a medical professional for any and all health-related issues. A link to our full medical disclaimer is available in the notes.